Welcome, everybody. My name is Lynn Wilson, and I'm the Vice President and Director of Patient-Centered Research for Myositis Support and Understanding. I am joined today by several of my colleagues, Jerry Williams, who is a founder and president of Myositis Support and Understanding, and our Chief Science Officer, Manuel Lubinas. I'm also joined by Yumi Park from Caregiver, and Dr. Roy Agarwal. And I'm going to talk about Dr. Agarwal in just a couple of minutes. I do want to say one thing, that today's Rare Disease Day, and we can't think of a better place to have this very important webinar. So thank you for joining us today. And with that, I'd like to talk a little bit about Dr. Agarwal, who is presenting poor long-term clinical outcomes and health-related quality of life in dermatomyositis and polymyositis. And again, thanks to Caregiver Life Science for sponsoring this absolutely seminal presentation. For those of you who know, Dr. Agarwal doesn't really need much of an introduction. He's a rock star in the myositis space. He's done so much work to educate doctors and educate patients through his wonderful series called Myositis 101. Dr. Agarwal's research and clinical areas of interest are clinical and translational research in inflammatory muscle diseases, myositis, and associated interstitial lung disease. He's past chairman of the Medical Advisory Board of the Myositis Association, as well as a past chair of scientific committees on IMAX, and which are a large patient-physician organization with working groups to promote new ways of looking at research in myositis, respectively. Dr. Agarwal is an independent clinical investigator with significant funding from the NIH, foundations and industry, and currently leading several collaborative international collaborations with other key leaders in the world. He's maintained an extremely high publication rate and receives national and international recognition of his work. He continues to be a leader in the disease criteria rationale, in disease criteria and outcome measures in myositis, as well as in clinical trials of novel therapeutic agents for myositis. He's currently the principal investigator or member of the steering committee for several international phase 2 and 3 clinical trials in the area of myositis and associated ILD. Dr. Agarwal is also mentoring the future generation of rheumatologists with great success in attracting younger rheumatologists toward myositis research for the advancement of the field. He lectures at various international conferences and promotes patient education through his YouTube channel. We are going to start the presentation with Dr. Agarwal in just a minute. I would remind you that we know you have questions. This is such an important topic, and we would like you to put your questions in the Q&A section at the bottom of the screen in the bar, and not in the chat section. We'll be monitoring that, but your questions should be put in the Q&A section. And we will address all of your questions as we can after the presentation. So now I'm going to turn it over to Dr. Agarwal, who will begin today's presentation.
Hello. My name is Dr. Rohit Agarwal, and I'm a rheumatologist and professor of medicine from University of Pittsburgh. I'm also the medical director of Arthritis and Autoimmunity Center, as well as co-director of the Myositis Center at University of Pittsburgh. Welcome you all here. Today, the topic would be poor long-term clinical outcome and health-related quality of life in dermatomyositis and polymyositis. In today's talk, we'll be talking about results from a systematic literature review summarizing the clinical and humanistic burden of dermatomyositis or DM, polymyositis or PM, and juvenile dermatomyositis or JDM in United States. Let us start with some basic understanding of dermatomyositis and polymyositis. First, I will describe the clinical presentation, epidemiology, and natural disease course of these enigmatic autoimmune diseases. Dermatomyositis and polymyositis are rare debilitating autoimmune disorders with primary target of muscle and or skin, but also impacts many other organs as shown on the figure on the slide. Dermatomyositis and polymyositis causes muscle inflammation. This muscle inflammation leads to damage of the muscle tissue, ultimately leading to loss of muscle strength, leading to poor physical function. Also, dermatomyositis patients may have skin rashes, which are characteristic features that differentiate dermatomyositis from polymyositis. These skin rashes include rashes on the eyelids or around the eyelids, called heliotrope rash, and rashes on the back of the hand called Gottron papules. Both dermatomyositis and polymyositis affect middle-aged patients in their 40s and 50s. Females are 2 times more common than male. Overall, in United States, we have about 120,000 Americans living with dermatomyositis and polymyositis. Now, dermatomyositis also affects kids and adolescents, which is known as juvenile dermatomyositis or JDM. The current therapies for DM and PM include corticosteroids or steroids, immune suppressive drugs, as well as immunomodulatory drugs such as IVIG. And in many cases, these drugs are ineffective in controlling patients' symptoms as well as maintaining response in many patients. Moreover, the prolonged use of these drugs are associated with various complications such as osteoporosis, cardiovascular disease, and metabolic disorders. As well as these drugs suppresses immune system, so can cause serious infections. Now, these complications overall contribute to significant morbidity and reduce patients' quality of life that we see in dermatomyositis and polymyositis. The natural course of dermatomyositis and polymyositis can be intermittent or could be chronic. The current standard of care, the immunosuppressive therapies, immunomodulatory therapies, and steroids are ineffective in many patients with dermatomyositis and polymyositis, and this is evident by the fact that about 62 to 67% of these patients do not achieve long-term remission. Moreover, the risk of mortality in dermatomyositis and polymyositis is quite high. An estimate about 10-year survival in dermatomyositis is only 53%, and in polymyositis is only 55%. Now, if you look at the juvenile dermatomyositis, what you see is 26 to 54% of juvenile dermatomyositis patients have chronic progressive course characterized by persistent disease activity despite all treatment. Moreover, 36% of kids with juvenile dermatomyositis have active disease even after 10 years of diagnosis. About 30% of all juvenile dermatomyositis are characterized as severe or very severe disease. Now, with that introduction about the disease, in next few slides, I will summarize the clinical burden, overall clinical burden of these autoimmune disease on patients' health. First, dermatomyositis and polymyositis patients experience frequent disease flares. Disease flare is defined as worsening of myositis symptoms that may require increase in the current therapy or additional treatment. Disease flares are reported up to 73% of dermatomyositis and polymyositis adult within past year, with exacerbation of muscle weakness being the most common reported disease flare. On this table, you see other common disease flare symptoms such as extreme fatigue and exhaustion, pain or discomfort, patients having trouble getting up from a chair or climbing stairs, as well as significant skin rashes and ulceration. Now, dermatomyositis and polymyositis flares overall lead to greater disability and pain. So the average number of flares in a year, higher is the patient's disability and pain, as shown on these graphs. On the left, you see the disability index increases as the number of flares increases per year, and on the right, you see the pain overall increases as the number of flares in a year increases. Now, to make matter worse, disease itself leads to increased comorbidities in a patient. Hospitalized adult dermatomyositis and polymyositis patients have significantly increased comorbidities as compared to patients without dermatomyositis or polymyositis, or as compared to patients with psoriasis or other autoimmune skin conditions. Overall, if you look at these comorbidities, you find that infection or serious infection are the most common comorbidities seen in hospital setting, followed by malignancy, followed by cardiac disease such as heart failure or congestive heart failure. Now, we also see the same increase in comorbidities in our juvenile patients. Children and adolescents hospitalized with juvenile dermatomyositis have significantly increased cardiovascular risk as compared to patients without juvenile dermatomyositis, with hypertension and arrhythmia being the most common cardiovascular diseases seen in these kids, and obesity being the most prevalent cardiovascular risk factor that we see in juvenile patients, and partly that is due to steroid use in patients with myositis. Now, infections and cardiovascular diseases are common causes of hospitalization and death in patients with dermatomyositis. In fact, infections such as sepsis and pneumonia, as well as various cardiovascular disease, may lead to excess mortality or deaths in hospitalized patients with dermatomyositis. Here are some examples given of those excess mortality or issues, such as mortality due to infection like sepsis and pneumonia is significantly higher in a hospitalized patient with dermatomyositis as compared to patients without dermatomyositis. Similarly, the hospitalized patient with dermatomyositis who have an underlying cardiovascular disease have significantly higher mortality due to congestive heart failure, as well as increase in myocardial infarction or heart attack than patients who only have dermatomyositis without these comorbid conditions. Now, in the next few slides, we will summarize the impact of DM and PM on patients' quality of life. Now, previously we discussed how dermatomyositis and polymyositis flare lead to significantly increased pain and disability. Now, let's look at the impact of these flares on people's quality of life overall in terms of the work productivity as well as their activities of daily living. As you can see that there are two graphs shown on the slide. On the left, we show that the percentage of work productivity loss due to myositis significantly increase as the number of flares per year or the last year increases. And on the right, you see that as the number of flares per year increases or the last year increases, you see there's also significant increase in loss of personal time or sort of non-work activity time, what we call as activities of daily living. So overall, you see there's a significant impact in work as well as at home if you interpret these data. Now, on this slide, we'll talk about how dermatomyositis can not only affect the physical, which we have discussed already, physical functioning, but also it can impact the emotional functioning of the patient. Now, patients with dermatomyositis report worse emotional well-being than patients with many other skin disorders, as evident by higher scores in Skindex 29 emotional domain. And you see that on this graph, we have dermatomyositis as one of the highest impacting the emotional scores on the scale, whereas other autoimmune and non-autoimmune skin conditions have much lower impact on patients' emotional domain overall. So, in other words, dermatomyositis not only affect the physical activity, work productivity, but also have significant impact on patients' psychological well-being or overall emotional well-being. Now, in the last few slides, I want to discuss about the impact of juvenile dermatomyositis or JDM on caregiver. The caregivers are quite important in cares of our juvenile patients because the parents and other caregivers also have significant impact from the disease itself that the patients or our kids are suffering. In fact, it will be fair to say that juvenile dermatomyositis actually affects the entire family system and not just the primary caregiver, with significant difficulties in family functioning, communication problems, sibling distress, as well as there is increased number of conflicts within the family, mainly because of the severe nature of juvenile dermatomyositis and lack of excellent treatment options. A series of excellent focus group assessed parents' perspective on emotional health impact of juvenile dermatomyositis on patients as well as families. The key emotional challenges included patient and parents' emotional health and family dynamics. Now, parents felt intensely overwhelmed with juvenile dermatomyositis related problems and stressors. They experienced sadness, grief, they had trauma at the diagnosis. Moreover, parents often endorse anxiety about present and future similar to the kids that are suffering the disease itself. Quality of life is the most relevant aspect of juvenile dermatomyositis according to the patients as well as their caregiver. On this slide, we show about 10 aspects of juvenile dermatomyositis care evaluated by patients and their caregiver. And quality of life, overall quality of life, was the most important factor rated by the patients and their caregiver, followed by timely diagnosis, access to rheumatologists, which is a major problem, normalization of patient's strength or function, ability to self-care, resolution of pain, resolution of fatigue, discontinuation of steroids, medication tolerance, as well as monitoring of medication toxicity overall. With this, let's discuss what are the major conclusions that we have seen in this study or this systematic review. So to conclude, dermatomyositis and polymyositis, including juvenile dermatomyositis, are rare inflammatory or immune disorders that have detrimental effect on multiple domains of life, which not only include physical, but also include psychosocial as well as social role functioning. Overall, these diseases impose substantial disease burden, indicating a significant need for a safe and effective therapy. As this study shows, both of these disorders are associated with poor long-term prognosis and significant increase in the risk of hospitalization as well as inpatient mortality due to underlying cardiovascular disease, infections, or malignancy. The current therapies that we have are often ineffective at controlling the disease symptom in many patients and are associated with significant side effects, especially steroid, that may contribute to significantly higher morbidity overall. We have seen that despite being treated with currently available therapy, many patients with dermatomyositis and polymyositis experience disease flare, which lead to significant increase in disability, as well as pain, as well as productivity loss at work, as well as loss of activities of daily living. So overall, it should be clear now, based on this study at least, that there is a significant high unmet need for novel, safer, and more effective therapies that will improve the long-term outcome of our patients as well as their health-related quality of life for our patients. With that, now I'm happy to take any questions. Thanks for listening to this talk or the results of this study. I hope this will generate a significant discussion on this topic. Overall, the disease burden, as you may have realized, of dermatomyositis, polymyositis, and juvenile dermatomyositis is quite high. And I will open the floor to questions now.
So thank you, Dr. Agarwal. And Manuel and Jerry, you're monitoring the Q&A. Would you like to start, please?
Yes, thank you. That was an excellent presentation. Michael asks, have you ever had a DM patient in long-term total remission taking no medications?
Yeah, so that's a very good question. So let me first explain what we mean by remission. We have two types of remission. One is remission on treatment, which basically means the patient is doing very well. They're about 95% better, 90 to 95% better. Sometimes we are not able to get them 100% better, but about 95% better. For all practical purposes, they're doing great. But they need some minimal immune suppressive therapy as sort of, to help them to continue doing well. And then another type of remission is the same type of patient state. They're doing great, but now they're off treatment. So we call remission on treatment or remission off treatment. Remission off treatment rates, at least in my experience, is about 10%. And remission on treatment is another 20%. So if you see overall remission rates are quite low, about 20 to 30%, but it still can happen and does happen. It takes several years to get to the remission state. So yes, the answer is yes, that does happen in about 20 to 30% of cases that the patient goes into long-term remission and does not have a problem thereafter. But it's only about 20 to 30%. That means we need better treatment to increase the remission rates to a higher percentage.
And if I could, before we go on to the next question, I would just like to let Michael know that I was diagnosed with dermatomyositis in 2015 at the age of 69. And I was started on low dose of prednisone and an immune suppressant. And I am now in full remission for 3 years with no medication. So it is possible, but we'd like to see those rates obviously go up. Thank you. So,
yeah. Thank you, Lynn. There's another question that Michael asked. So I think we might just go ahead and ask that. And this kind of goes to the same topic, treating DM without prednisone and immune suppressants using sub-Q IG and low dose naltrexone. Do you ever use LDN to treat DM?
Yeah, I think this is multiple questions. So let me try to answer this one by one. I think the first question is, do you treat dermatomyositis without prednisone and immune suppressant? And the answer today would be yes. In past would have been no. In past, we would never treat somebody without prednisone or immune suppressive drugs. But today we are able to treat dermatomyositis by a class of drug that we call immunomodulator. They're not sort of immunosuppressant, but they're an immunomodulator. For example, IVIG and sub-QIG would be a perfect example of the drugs which are called immunomodulator and not immunosuppressant or steroids. So there are few patients that we don't like to give prednisone or immune suppression, whether it could be due to their history of diabetes or some other reason. And we start them right off the bat, on sub-QIG or IVIG. Now, so yes, we do use our sub-QIG. In fact, I would be happy to report today to everyone that who may or may not know that IVIG is an FDA approved and a European agency called EMA approved treatment for dermatomyositis. And it got an FDA approval last year. Now, coming to low dose naltrexone, the reason sometimes dermatomyositis patient may need low dose naltrexone is because sometimes what happens is their disease get better in terms of their muscle weakness get better, their skin get better, but they have this lingering fatigue. And that happens because even though the disease has been taken control of, but the disease has caused them some damage to the muscle. And those damage is very difficult to recover. So what happens is that these patients experience muscle pain and fatigue. And for that particular fatigue area, low-dose naltrexone could be sometimes helpful. Now, having said that, I personally have only given low-dose naltrexone once or twice to a patient who were having significant fatigue despite all the treatment. So I don't have much of an experience with low-dose naltrexone, but I know it could be a treatment for patients with fatigue and diffuse pain as well.
Wow, that's really interesting to hear. We had a talk about this in one of our support groups the other day, and I wasn't aware that that was a treatment that could help with the fatigue and pain. So I'm sure that's helpful to all of us. Thank you. Healy asks, are there any successful treatments for calcinosis?
Yeah, let me honestly tell you something about calcinosis. When my patient with dermatomyositis comes with calcinosis, I want to run away from that clinic because I'm so embarrassed that I don't have much to offer to that patient. Calcinosis is one of those areas which is the most debilitating for our patients. And to make matter worse, is the most difficult to treat for the doctor. So as a myositis expert, I feel really not good about it, that I'm not really able to offer an excellent treatment for calcinosis. Now, having said that, we do offer treatment, not perfect, but we do try to improve patients' life by number one principle for calcinosis treatment is the disease under control. Because an active dermatomyositis patient would have a lot more problem with calcinosis as compared to dermatomyositis patient whose disease overall is under control, but the calcinosis is ongoing. So first and foremost rule is to get the disease under control. Then in terms of specific treatment for calcinosis, IVIG has been proposed as one of the options. Warfarin has been proposed another option. Bisphosphonates, like drugs like Fosamax, have been used as well. All of these drugs have been used for calcinosis with minimal success. The good news is that there are two treatments that are under investigation. One of them is called Xeljanz, and there's a study on this drug class of drug called JAK inhibitors. The drug called Xeljanz was studied in 10 patients and showed improvement in dermatomyositis patient skin, including calcinosis. And another juvenile study actually showed specific improvement in calcinosis. Now, it's tough to say whether that improvement in calcinosis is directly related to the drug or drug was just improving an underlying dermatomyositis disease activity, and as a result, calcinosis improves. Another drug that is under investigation is sodium thiosulfate, I think it is. I don't give that drug, so I don't know, but basically there's a trial going on at NIH to give this drug specifically to patients with calcinosis. And the results of the study is not public, but what I've heard that it does help some patients. So with that little bit of good news, the two drugs under investigation for calcinosis, we might get better news in next few years.
Great, thank you so much. I know that's something that's on top mind for some people, and that trial at the NIH, I believe, is still enrolling, if I'm correct.
Yep.
Okay, great. Mary asks, has COVID helped to uncover any treatments for interstitial lung disease?
COVID helped to discover treatment for interstitial lung disease. Tough to say. In fact, the treatment for dermatomyositis or interstitial lung disease secondary to dermatomyositis has helped us to test some drugs for COVID, and it has helped. For example, Xeljanz, and I think, the baricitinib is a JAK inhibitor, which is approved for COVID treatment, especially moderate to severe COVID. And we know that JAK inhibitor does tend to work in dermatomyositis, including rapidly progressive interstitial lung disease with MDFI positive antibody. So I think to some extent, yes, we have learned some lessons from COVID, but specifically in JAK inhibitor line, because MDF5 dermatomyositis lung disease looks very similar to COVID lung disease. They're very similar to each other in terms of a lot of aspects. So yes, we have learned to some extent, especially in JAK inhibitor, the fact that the JAK inhibitor works for COVID, as well as it works for MDF5, ILD, kind of would be one of the examples there.
Great, thank you. Beverly is asking information about brachiocervical inflammatory myopathies.
Yeah, so brachiocervical inflammatory myopathies is sort of a rare manifestation of inflammatory myopathies. And it's unfortunate that it doesn't get put into the category of inflammatory myopathies often, but it should be perhaps a distinct entity, like we have polymyositis and so on, because it does have a distinct clinical features. Basically, for me, it's an inflammatory myopathy that affects certain muscle more than the typical muscles. So I typically treat brachiocervical inflammatory myopathies as I would treat a patient with polymyositis. And we have seen, some success, although you have to understand this is a much rarer form of inflammatory myopathy. So so the information that I would like to share is, your doctor should treat it as if they're treating a polymyositis patient.
Great. I'm sure that's very helpful. Thank you for answering that. Let's see. Angelic I have acquired remission since 2006 and have not been screened for any cancers or other possible health issues since '07. Should I continue to consult with my doctor even though I'm not having any particular issues?
Yeah, I mean, if this is a 10-year or more, that's a very safe time point where I would say perhaps you're not going to see a problem in future. Now, I say perhaps because I have seen one patient who saw me after 12 years of being in remission and came with a flare. So I would never say, that no for sure, but most patients when we see, if they have passed 5 years of remission, they're in a very safe zone. Likelihood that they're not going to have any problem. But if they're past 10 years, which is like in your case, it's extremely, extremely rare that you would have any flare-up or problems. But it can happen, though, rarely.
Yeah, highlights the complexity of the disease.
Yeah.
Thank you. Anna asks, have you ever had any patients able to completely get off of oxygen?
Yes, that depends on the severity of the lung disease. So right. We have had patients who come in with more severe lung disease where they go on to oxygen, and on treatment of their lung disease associated with myositis, they are able to get off oxygen. But the key there is that those patients, main patients who are able to recover so well on treatment are the patients who present early. The patients who have had disease for years and years and are on oxygen for years and years, those are difficult to improve to an extent they're able to get off oxygen. The best example I would give is when somebody comes in, we're doing great, and few months history, they got acutely worse in their breathing. Now they have to be on oxygen. We treat them in a year or two, they're able to get off oxygen. That's the best scenario. But another scenario would be patient comes in and have been on oxygen for 5 years, and we look at their lung and their lung has severe disease. Those patients will be very difficult to be able to get off oxygen. One thing I would highly recommend to patients with lung disease, apart from the medical treatment, the pulmonary rehab or pulmonary exercise of the respiratory musculature is extremely helpful to decrease your oxygen needs and increase your function. So please focus there, because that's something the patient can do themselves. There are many videos on pulmonary rehab, on pulmonary respiratory exercises. In fact, yoga also has many respiratory exercises. So you need to look into those, because those can increase your overall lung capacity, and that decreases the overall patient's function as well as decrease oxygen requirement.
Yes, that's excellent advice. That's something that we've also talked a lot about in our support groups, is pulmonary rehab and the benefits that we've seen some of our members achieve. So thank you. Courtney, if a DM patient hasn't responded to prednisone and 3 doses of IVIG, would you begin to consider them refractory?
I think so. Now, by 3 doses of IVIG, it depends on what you mean by 3 doses. Are you talking about 3 cycles of IVIG every month? That means you have been on, you got 1 cycle, then you got another cycle a month later, then you got another cycle a month later. Typically, we start to see response on IVIG at about 3 to 4 months. So if it has been 3 months and you have had no improvement, I think you got to be considered as refractory and move on to other treatment. But if it's only 3 doses and it's only the 1 month that you've received 3 doses so far, then perhaps you should wait.
And just for the audience, could you explain what refractory is?
Yeah, so refractory means that the patient has failed one or two immune suppressive drugs. That means typically we call refractory somebody who has failed prednisone and additional immune suppressive or immunomodulatory drugs. So steroids plus another drug, if you have failed, that's what we call refractory. In fact, most clinical trials will take patients who are refractory. So maybe I would even encourage Courtney to look into clinical trials. There are really good clinical trials going on, including one by Kezar. I know they have completed recruitment, but other clinical trials are open, and I would encourage patients to join one of those clinical trials, especially if you are not responding to the first-line treatment.
Excellent. Thank you. This is a really, really good question that I don't know that has been addressed in a while. How often are gastric issues reported in DM?
In juvenile dermatomyositis patient, it's quite common to have gastric issues. In adult dermatomyositis patient, the gastric issues are two types. One is when you have upper gastric issue, which means esophagus issues, where you have difficulty in swallowing. So your swallowing apparatus is made up of skeletal muscles, similar to the muscles we have in our arms and legs. So the patients have difficulty in initiating of the swallow and also push the food down into the esophagus. Now that happens in adult quite often, especially more severe disease. The other type of gastric issue is lower GI, which is stomach or beyond that. That doesn't happen commonly in adult dermatomyositis due to disease. That happens more due to medication, such as steroids, mycophenolate, methotrexate. All of these can cause gastritis and diarrhea or constipation. In fact, can cause GI infection like CMV infection. So it could cause gastric issue, but not directly to dermatomyositis as a disease, but more as a side effect of the medication.
Okay, I'll take over some of the questions from Gary that were right now going on. I think another question that I thought was very interesting, and I think going back to, there's a lot of questions on MDFI in the group. So I think that for some reason, MDFI always brings a lot of interesting things. One is like comorbidities of MDFI and cancer and ILD. What type of comorbidities show up after MDFI is diagnosed? Do they show up before cancer, after diagnosis?
So MDF5 is very interesting. First of all, MDF5 comorbidities, including interstitial lung disease, mostly show up within 1 year. So that 1 year time period is critical for MDF5 patients. Once you've passed that 1 year time frame, we do not see so much of, and let's say 1 year has passed and you have not developed interstitial lung disease, or you have interstitial lung disease, but it's stable. We don't see much of a problem going long term with MDF5. So that's a good thing. The only thing I would say is cancers is a risk in MDF5. It's not a very high risk, but it's not a low risk either. So it's sort of an intermediate risk. And up to 3 years, you should look for cancers in MDF5 patients because of its intermediate risk. But for ILD, if you have not developed ILD in 3 years, I wouldn't worry about it.
Great. Another question related with cancer as well. This is from a young patient diagnosed with DM at 25. And she's asking if it's malignancy is still a large issue. And I don't know if it's MDFI or it would be another type of antibody on those cases. What should be the concern of a patient with malignancy?
Yeah, so I have to say the younger the patient, lesser is the risk for malignancy. So basically, age is a major risk factor for malignancy in dermatomyositis. So typically, I would say younger patients don't have much of a malignancy risk. But having said that, there are other risk factors. For example, which myositis autoantibody you have may increase or decrease that risk. So this patient hasn't told us what autoantibody she has. Right. That might make a huge difference. But even in a younger patient, we still recommend malignancy screening every year for 3 years total.
Great. And I will take another question here from Benita, who is also talking about the studies with MDFI. And that's kind of maybe what future studies are we doing like are specific to antibody patients? Is that like this subclassification of myositis or dermatomyositis by antibody type and kind of the different responses that they may have in these studies?
Yeah, so the good thing is myositis specific antibodies are very helpful. If you know which myositis specific antibody you have, you can almost predict to large extent what kind of course you're going to follow. For example, if you have TIF1 gamma antibody, you got to be really worried about cancer. You may want to do a CT scans and PET scans to make sure you don't have cancer. And if you find cancer early, then you treat it. If you have MDF5 antibody, then you're worried about lung disease for at least a year from your diagnosis. If you have antisynthetase syndrome, then you're worried about interstitial lung disease, but somewhat of a different nature than MDF5. So autoantibodies can give a lot of information about prognosis and what organ can cause the most problem, and you then proactively monitor that and address the issue right away.
Yeah, and I think the follow-up from my side on that question is like, are we in a point in the future where we are looking at responses depending on the antibody for like measuring clinical trials? And is that something that you envision to have?
In future, in fact, not in near future, we are going to have trials which are autoantibody based. In fact, we currently have trials which are autoantibody based. For example, I'm just completing a trial where we looked at it only antisynthetase syndrome patient. And I know there are trials that are coming up which will look at patients who are anti-MDF5, HMGCR, and other autoantibodies. So yes, we are starting to see that autoantibody based studies is still a problem because it's a rare disease. And when you break it by autoantibody, it becomes rarer. So it's still a challenge, but at least we are starting to see autoantibody-based disease subsets in clinical trials.
Yeah, great on that one. So another question that I think is important for many patients that Shona is asking is, how important is the early and aggressive treatment, right? We have many patients who are around the country and they are not able to get to a specific center. They are not able to get to you in Pittsburgh or Mayo Clinic or somewhere else. And they sometimes find that they are not getting the aggressive treatment they need. What do the studies indicate in this area?
Yeah, so early treatment and aggressive treatment is the key for myositis. The earlier you treat myositis, better the outcome. There is no doubt, because more the time passes, patient develop damage, and no treatment can reverse damage. So the earlier the treatment, lesser is the damage and better is the recovery overall. Aggressive treatment depends on the severity of the disease. Like, for example, I would be very aggressive for a patient who present with moderate to severe disease. I may not be very aggressive on a patient who comes in with milder disease. Because remember, these treatment, when you say aggressive, that means you're talking about multiple immune suppressive drugs or changing immune suppressive drug rather quickly. And that itself can have some side effects or adverse event.
Correct.
So we only do aggressive treatment when we feel patient is either severe or refractory, or for some other reason, we know this patient may not do well. For example, if the patient have SRP antibody, then I will be aggressive from the day one, because I know most patients with SRP antibody have refractory disease and so on.
Yeah, and I think that leads me to the next question that is also related, which I think is, what is the best treatment for DM when is the main issue? It's like a specific one. She's currently in 25 milligrams of Metoject, 100 milligrams of hydroxychloroquine, and she was not able to increase that due to an adverse reaction of the skin. Which to me is a bigger question, is like, is there like the standard treatment for DM? And I think you kind of mentioned already some of that.
Yeah, the standard treatment for DM, the first line treatment would be a little bit of steroid along with methotrexate or azathioprine. So that's the first line treatment. When somebody fails the first line treatment, or for some reason first line treatment is not favorable, for example, if somebody has liver disease, you won't give them methotrexate, or if somebody has diabetes, you may not give a prednisone. In those situations, you can go to the second line, which would be, in current situation for dermatomyositis, it will be IVIG or sub-QIG for that matter. Not all patients are able to tolerate IVIG or sub-QIG. There's a cost issue, there's a logistical issue, and there are side effect issues. But starting with methotrexate or azathioprine plus steroid is probably the best first strategy.
That's good. And since we're still in treatment here, I think there was another question from Julie. Like, for example, if a skin is the main issue, do we see different treatments from patients who are skin of like CADM versus non-CADM? Where are we on that right now?
Yeah, so the skin does have somewhat different immune suppressive regimen. For example, if the skin is bad, I may start with IVIG right away. Or if skin is bad, I may go to mycophenolate right away. If the skin is mild to moderate, I think still methotrexate, Immuran, steroid, all those drugs still work. But in a bad skin situation, IVIG and mycophenolate would be my drug of choices.
Great. So I think this is another question I missed before. Is CVID a common comorbidity and DM and PM? CVID. That's increased.
What is? Yeah. I'm not sure what CVID refers to.
Yeah, I was not sure either.
Common variable immunodeficiency syndrome?
Yeah, maybe we wait for the response from
yeah. So CVID, I'm not sure which one. Yeah. But if the CVID means common variable immunodeficiency syndrome, then yes, it is a comorbidity for dermatomyositis and polymyositis. If basically what happens is in these patients is as they get immune suppressive drug, their immunoglobulin, total immunoglobulin levels drop. When the total immunoglobulin levels drop, they get infections. And that can lead to increased morbidity and mortality.
Correct. Yeah, so I think that's clear from that. Debbie's asking if there are immunomodulator drugs used instead of steroids in PM patients as well as DM patients. And I think you already touched on that already.
Yeah, RA drugs or immunomodulatory drugs would be, currently immunomodulatory drugs are IVIG and sub-QIG, although there are other drugs in development. I mean, for example, the KESAR clinical trial, the KZR 616, we have to wait for the results of the study, but it could be considered as immunomodulatory rather than immunosuppressive. But only the data will tell which category does it belong to.
And since I have many questions on patients who kind of define themselves as PM and DM, I always like to ask the same question. Like, what should do a patient who has been diagnosed with PM for the last 10 years? You know, because we have now a whole different vision of PM patients. Should they still be keeping up their PM diagnosis, or should they look for a kind of
it's tough because there is still a PM diagnosis.
Yeah.
So previously, 20 years ago, a PM diagnosis could have been an IBM, or which is inclusion body myositis. A PM diagnosis could be NM or necrotizing myopathy. A PM diagnosis could have been antisynthetase syndrome, or a PM diagnosis could be a true PM. So it's tough for me to say without seeing you, which type of PM do you have? Do you truly have PM? Or you're more of antisynthetase category, or you're more of necrotizing myopathy category, or you actually have inclusion body myositis. The good thing is if your treatment is working, then you probably don't have inclusion body myositis. But you probably have one of the three, either true PM, NM, or antisynthetase. But it really doesn't matter as long as you're doing well. It matters more if you're not doing well, because then your doctor may have to give a specific treatment.
Yeah, I think we have a listener from Italy who said that they only get IVIG if you are really bad. What is your opinion about that? It's like IVIG only approved later on in treatment.
No, actually, if you look at the approval, IVIG in Europe is approved for any adult dermatomyositis patients. The problem is that it's country specific. They have made some rules and regulations because IVIG is rather expensive and is difficult to get. So they've made some rules and regulation which makes it difficult for the doctors to order and the patients to get IVIG. So that's why more severe patients or more refractory patients get IVIG. But as an indication, we have patients with mild disease, moderate, and severe disease in IVIG clinical trial, and all three categories improved.
Yeah. There is another question from Joanne, and it's asking about pain, right? So there is a belief still that PM does not cause pain, patient pain, I think PMDM, but only weakness. And of course, we have done in MSU some studies and done surveys about how many patients have pain, and we have concluded that many patients in DM actually show the most pain. But just curious about what is your opinion about that? Like, still believe that pain does not exist in DM, and where that kind of.
I think this, first of all, this is completely false. Pain does exist in PM. We have done some studies and others have done studies. As you were saying, you've done some studies. It's clear that the pain plays a significant role in patients with polymyositis and dermatomyositis. It's the problem with the pain is there are two types of pain in PM and DM world. One is the pain that comes from disease activity. And one is the pain that comes because of disease damage. The pain that comes from disease activity improves on treatment with immune suppressive condition. The pain that is coming from disease damage does not improve. In fact, lingers for years after the disease is even in remission in some cases. So we haven't paid too much attention to pain in myositis, and we should. In fact, I am happy to report that almost all clinical trials going forward will measure pain in myositis as an outcome for these clinical trials. So I have been advocating to measure pain in our patients on a regular basis.
Yeah, and I think that another question that I think related to this description of drugs that we currently use for myositis is the use of off-label drugs for myositis, like Rituxan, for example. And we know that sometimes people have a lot of problems getting approval with the insurance. And I think people I know that the Rituxan clinical trial for DM was not approved, but what is going on in terms of getting more of these drugs that maybe failed in the past and kind of approved, because you have a lot of different drugs being used?
Yeah, so drug approval is a major issue. So the main reason we did IVIG trial, even though we knew IVIG works, was to get IVIG approved and now it's tough for insurance company to not, to deny it completely. Rituximab has the same problem. We know rituximab works in subset of patients, but it's tough to get it approved because we tried to get it approved. Unfortunately, we were not successful to get it approved. But for a good thing is there are multiple clinical trials going on now with new treatment, where if you participate in the trial and the trial is positive, once the drug is approved, it becomes very difficult for insurance to deny it. But an unapproved drug, it's very easy for your insurance to deny it. So that would be my plea for your patients to join clinical trials, because not only are you going to help yourself, but also you're going to help a lot of other patients in future.
Yeah, and I think, for example, you confirmed that patients shouldn't get any problem right now getting IVIG as an FDA approved in their treatment, right? Yeah, well, theoretically.
Well, I won't say they won't get any problem. I would say it is difficult for insurance company to deny an FDA approved or EMA approved treatment, where it's much easier for them to deny. You still may have some trouble, but your doctor and patients, if they work together and continue to pursue, they will eventually be successful for an FDA approved drug, but they could be not successful if the drug is not FDA approved. That's the importance of getting these clinical trials, because these clinical trials will make sure if they're positive, then the drug is approved, and then you have access to those drugs.
Yeah, and I think to the same token, I think there was a question about Xeljanz and approval for DM, and I don't know if there is any kind of.
So Xeljanz per se has one clinical trial going on in, I think, UK, which is not a regulatory trial, which basically means that even if the trial is positive, it may not get an approval. But there is another trial which might be undergoing with a similar agent to Xeljanz, which may be a phase 3 trial and would go under regulatory approval if the drug does work. So we do not have specifically for Xeljanz, but we have similar drug to Xeljanz that is currently being studied in clinical trial.
And and I think those are kind of the JAK inhibitors. And I think in juvenile dermatomyositis have been a lot of studies on some of those. So Is this also, you think, a new category for treatment? You see a prospectus and JAK
Oh yeah, I see strong possibility in JAK inhibitors.
Great. Let's see what else we have. This is a question that always comes in. Do DM have elevated liver enzymes like ALT, SST?
So the DM can have AST and ALT elevation, but most of the time their AST and ALT elevation is not due to liver problem. Although these enzymes are called liver enzymes, they also come from muscle. And because their muscle is inflamed, they can have AST and ALT elevation without having any problem in their liver. In fact, that's most common the scenario that their primary care doctor and other doctors get scared that their liver function is elevated. And I tell them, listen, it's not their liver function, it's their muscle that is inflamed. And that's why they have AST and ALT elevation.
Yeah. So I have another patient here for refractory DM, and I kind of like to hear some of those. I was told my cardiologist is probably just all going through. So let's see. I experienced SOB and currently taking metoprolol. I see pulmonary and cardiology. However, all the tests, they have completely shown no issues with my organs. I am told by cardiologists probably just from all is going through. I'm not okay with that response. How do you treat anyone like this?
I don't think I got the question completely. Could you repeat?
Yeah, so this is a patient who has refractory DM and experienced SOB and currently taking metoprolol. So he's saying the pulmonary and the cardiologist, but they have completed no issues with the organs. And he was told,
So the patient having shortness of breath, and patient was told that the patient has no issues with the lung or heart.
Right, correct. And the patient is still worried about that.
Yeah, that something could be due to respiratory muscle weakness. So if the lung doctor thinks that you have no lung disease and the heart doctor thinks that your heart is okay, then you need to think about, have them or your doctor or myositis doctor think about, could there be respiratory muscle weakness, which is a diaphragm weakness that can cause shortness of breath. And also pulmonary artery hypertension should be looked into because that itself can cause shortness of breath. So apart from lung and heart, shortness of breath can happen due to muscle weakness, respiratory muscle weakness or diaphragm weakness, or it could also happen due to pulmonary artery hypertension. So look into those two things.
Yeah, that's a good question. I don't know how much more time you have because you're almost time to 11 o'clock.
Yeah, so one thing I would like to say that, for patients here who have joined, if you, want to stay connected to me, please look into the myositis YouTube videos that I have on myositis 101. And I will try to provide more information coming in future. It's just the time I would love to put a lot more videos. It's just the time is limited, but at least if you can join me and, if you have any questions, you can post questions there as well.
Yeah, I think the question from our side, from organization, is what else can we do as patients, to be proactive and help in some of these clinical trials that are going on and kind of help model some of those things?
Yeah, so what the patients can do is patients have a lot of power. What they can do is if their clinical trials come up, studies come up, even if a patient himself or herself cannot join the study, they can through social media, promote that clinical trial. Because there is no regulation, patients can talk to other patients. Patients can, use social media to tell other patients, look, there's a clinical trial going on. I may not be eligible, but look, if you are eligible for this clinical trial.
Perfect, excellent. I don't know if Lynn has anything else to say at the end?
Yes, the only thing I'd like to say is thank you, Dr. Agarwal, for bringing this to the forefront. I mean, there are a lot of issues here around effective treatments, a lot of things around the burden of care that patients have, and raising the voice of the patient to support your research and others that are looking into these issues. One of the things that we will do, one of the things that we are doing in that area is, of course, we're hosting an FDA listening session on adult dermatomyositis coming up in April. And this is our effort to raise the voice of the patient and the issues to the FDA. We're also close to publishing our pain study, which also supports your study here in terms of pain and myositis. And so those are the things that we are doing to elevate the voice of the patient. And I can't think of anything else. Again, you're a rock star. We love you. And just thank you for taking the time to do this. This is very, very informative.
Sure. Thank you. Thanks for inviting me. Thanks to Kezar and MSU.
Yes, thank you so much, Dr. Agarwal. Thank you, Kezar. We appreciate the sponsorship of this wonderful event. For those of you that are living with myositis, join us for peer-to-peer support. We have so many support groups where you can meet and talk about all of this stuff. Thank you so much for all the great information. And Dr. Agarwal, if you could just repeat one more time, can pain be a part of myositis?
Yes.
Thank you. Thank you. Thank you.
And also, I forgot, we will take the questions out of the Q&A that were not answered. We will capture those so that perhaps Dr. Agarwal can further the discussion of that in his Myositis 101. Thank you.
Sure. Bye.
Bye-bye.
Bye-bye.
Thanks, everyone. Have a wonderful rest of your rare disease day.